All right, welcome back. Today we're putting on our detective hats to crack a classic clinical case, the stiff and painful shoulder. Now, you're going to see this a ton in practice, but getting the diagnosis right takes some real investigative work. So, let's get into it.
So meet our patient, a 54-year-old office worker. Comes in with a shoulder that's gotten progressively stiff and painful over the last 3 months. And here's the key clue: no specific injury. They didn't fall, they didn't lift something heavy, it just started. So right now, what's your gut telling you? What's at the top of your suspect list? Hold that thought, and let's see if the evidence agrees. So here's our game plan. We'll start with our patient's story. Then we'll build a detailed profile on our number one suspect, frozen shoulder. After that, we dive into the clinical investigation, the real nuts and bolts, before lining up a few other potential culprits. And finally, we'll put all the pieces together to crack the case. Okay, let's bring in our prime suspect, frozen shoulder. The official name, the one you'll see in the textbooks, is adhesive capsulitis. We really need to unpack what this is and how it operates to see if it fits the profile of our case. So what exactly is adhesive capsulitis? Well, at its core, it's a 1-2 punch. First, you get this wave of inflammation inside the shoulder joint. Then, that's followed by fibrosis, which is just a fancy word for the joint capsule itself getting thick, sticky, and tight. Now, sometimes this happens for no reason at all. We call that primary or idiopathic. Other times, it's secondary, meaning it's triggered by something else, maybe an old injury, surgery, or a systemic disease like diabetes. The classic story of a frozen shoulder usually unfolds in 4 acts. It kicks off with a pre-inflammatory stage. Think sharp pain at the very end of your range of motion, and, crucially, a really tough time sleeping. Then comes the freezing stage, where the pain really ramps up and you start losing that key movement, external rotation. Next up, the frozen stage. It's pretty much what it sounds like. A major, global loss of movement, and it still hurts. And finally, you get to the thawing phase. The pain starts to back off, but that frustrating stiffness can stick around for a long, long time. Now, while those 4 phases are great for the textbooks, in the real world, it's often way more useful to simplify things. Most clinicians think of it in 2 dominant phases. First, you've got the pain-dominant phase. This is basically the pre-inflammatory and freezing stages rolled into one, where the patient's number one complaint is, you guessed it, pain. Then, things transition to a stiffness-dominant phase, where the main problem is that profound loss of motion. It's just a much more practical way to approach treatment. So who tends to get this? Well, there's a pretty clear profile. The average age is right around 50. Sound familiar? Just like our patient. It's also much more common in women. And the time course? It can be brutally long, anywhere from 1 to even 4 or more years. But the really big thing here are the risk factors. You have to ask about things like diabetes, thyroid problems, and even family history, because having one of these makes a frozen shoulder diagnosis much, much more likely. Okay, time for the investigation itself. This is where we stop theorizing and start gathering the hard evidence, combining the clues from the patient's story with what our hands tell us during the physical exam. The subjective interview is where you find your first batch of clues. You want to map out how the symptoms have progressed. Does it sound like that classic shift from pain-dominant to stiffness-dominant? You're digging for those comorbidities we just talked about, diabetes, thyroid, all that. And you got to ask about sleep. If they tell you their sleep is absolutely wrecked by the pain, that's a huge red flag for that early, highly inflammatory stage. And now for the physical exam. This is where we get our objective, undeniable evidence. And listen up, because this is probably the single most important finding in a true frozen shoulder. The patient's active range of motion is equal to their passive range of motion. What does that mean? It means they can't lift their arm and you can't lift it for them either. It's a true mechanical block, not just weakness or pain. And you'll see this limitation in multiple directions, but the big one to watch for is external rotation. And here is the magic number. If you measure their passive external rotation and find that it's restricted by more than 50% compared to their good side, bam, that is a massive clue. Frozen shoulders should immediately jump to the absolute top of your list. It is a key diagnostic indicator. So what about x-rays? People always ask about imaging. Here's the deal. With a frozen shoulder, the x-ray is usually going to look completely normal. Its job is not to rule in frozen shoulder. Its job is to rule out the other suspects that might be lurking, like bad arthritis or other issues with the bone. Okay, any good detective knows you can't get tunnel vision on just one suspect. You have to consider the alternatives. So let's bring in the rest of the lineup for a stiff and painful shoulder. First up in the lineup is glenohumeral osteoarthritis, or OA. The big difference here is often the age. Primary OA usually shows up in folks over 60. The onset is different too. It's more of a long, slow, smoldering ache compared to the more intense pain you see in early frozen shoulder. And of course, the X-ray will tell the tale. With OA, you'll see stuff like joint space narrowing and bone spurs.
Another suspect, a bit less common but super important not to miss, is avascular necrosis, or AVN. This is a pretty serious situation where the blood supply to the head of the humerus gets choked off and the bone literally starts to collapse. You've got to screen for risk factors here like long-term steroid use or excessive alcohol intake. And let's not forget rotator cuff arthropathy. Now, this isn't your average rotator cuff problem. This is a type of arthritis that develops after a massive, long-standing cuff tear. The mechanics of the shoulder get all messed up, and the head of the humerus actually starts to drift upwards. And you can see this on an X-ray. You'll see that the space between the bones has shrunk, which is something you just don't see in a classic frozen shoulder. All right, we've interviewed the witnesses and checked the records on all our suspects. Now it's time for the big reveal. Let's apply all this clinical reasoning back to our 54-year-old office worker and crack this case. So, let's bring it all back. 54 years old, a gradual onset over 3 months, pain and stiffness, no trauma. All the pieces are on the table. How do they fit together?
This is where a matrix like this is so helpful. It lets us weigh all the evidence side by side. Look at the age, 54. Perfect for frozen shoulder, plausible for rotator cuff pain, but pretty unlikely for primary OA. Now look down at the physical exam findings. This is where the case really breaks open. See that row for active ROM? For frozen shoulder, active equals passive, but for rotator cuff pain, active is less than passive. Then you look at resisted tests. Strong and painless screams capsular problem, like a frozen shoulder. Weak and painful, that's your classic rotator cuff issue.
So, what's the verdict? Well, based on everything we've gathered, we can confidently narrow our investigation down to 2 top suspects, frozen shoulder and rotator cuff shoulder pain. Primary OA is way down the list. And the key takeaway here is that your hands, your physical exam, will be the ultimate tiebreaker. That simple comparison of active versus passive range of motion is what will let you nail the diagnosis. So, as you can see, diagnosing a stiff and painful shoulder isn't about some magic test. It's about being a good detective. It's about knowing the profiles of the usual suspects and, most importantly, knowing which pieces of evidence really matter. If you take one thing away from this, let it be this. Master the difference between active and passive motion loss, and you will solve the vast majority of these cases. So I'll leave you with this question to think about. When that next stiff shoulder walks into your clinic, what's the one crucial piece of evidence you'll be looking for first? Thanks for joining me on the case.